In this episode, we discuss the two important short-term complications of diabetes, including diabetic ketoacidosis and hyperglycemic hyperosmolar state. First, remember that DKA is more common in type 1 than type 2, while the other type of the complication, that is HHS, is almost exclusively seen in type 2. So let's start with DKA and its risk factors. What are they? Infection, trauma, alcohol consumption, non-compliance with anti-diabetic medications. Now, what are the progression of the symptoms in DKA? The first symptoms could be weight loss, or the 3 P's of diabetes, the polyuria, polydipsia, polyphagia, as well as blurred vision. What are the next step symptoms of DKA? In the more progressed state, the patient may have abdominal pain, nausea and vomiting, small breathing, altered mental status, the fetohepaticus, and the signs symptoms of dehydration. What's the mechanism of dehydration? Usually osmotic diuresis. Also, please remember that in a minority of cases, DKA could be the initial presentation of diabetes. It's important to know that because you cannot always expect the known diagnosis of diabetes for the diagnosis of DKA. Now, what is the mechanism of DKA? It's insulin deficiency. Why is it important? Later on, when we discuss HHS, we mentioned the mechanism is not insulin deficiency, but either insulin resistance or excess counter-regulatory hormones. Because of that, we do not have ketosis or acidosis in the setting of HHS as opposed to DKA. So what are the initial workup for the patient suspected with DKA? The workup, of course, initiates with blood glucose as well as assessment of acid-base status and calculating an ion gap. We also measure the ketones in serum and urine and serum osmolality. What is the lab formula of DKA? A blood glucose between 250 to 600, maximum 800 based on some resources. High anion gap, metabolic acidosis, that is sodium minus the anions, which is bicarb and chloride, is greater than the upper limit normal of 12 to 14, and bicarbonate is lower than 18, and serum osmolality, which is less than 320. That is the normal value of osmolarity in the millismol per kg reference. Now, what is the most important reason for checking electrolytes? Assessment of potassium level. What are the possible changes? Even though the evaluated value could be normal or even high, the patient has total potassium deficit in the body. Why then we could have normal or abnormally high readings in potassium measurements? For two reasons. One is acidosis that shifts the potassium out of the cell, and the second is insulin deficiency. Always remember that insulin inserts potassium into the cells. Why we have total body potassium deficit despite these falsely normal or elevated levels? For two reasons. One is because of osmotic diuresis. Always remember that the major force for potassium loss in distal nephron is the flow and electrochemical gradient in the distal nephron. And also the second reason is because of this dehydration. Due to osmotic diuresis, we have activation of renin-angiotensin-aldosterone system with further loss of potassium. What other electrolytes are of relevance to measure? Phosphate, sodium, and chloride. Why measurement of sodium is important? Because it can guide the choice of fluid therapy after the initial couple hours. For example, we know that the patients with normalized or increased levels of sodium should receive half saline or add some dextrose water, 5% dextrose, instead of the initial fluid that's always normal saline. The second significance of sodium measurement is to be able to calculate the corrected real value of the sodium. What is this? formula. Always remember the corrected sodium value is the measured sodium value plus 2 milliequivalent sodium added for each 100 milligram glucose more than 100. For example, if the patient's measured blood glucose is 600, it is 500 more than 100, so we need to add 5 times 2 to the measured sodium value to get to the corrected sodium value to figure out if the patient has hyponatremia, if his sodium is corrected, or if he's hypernatremic. True or false, after the initial assessment, the next step in the management of the patients with DKA is etiologic workup. That is false. We always initiate the emergencies with ABC vital sign stabilization. Then we move to any needed initial screening or testing to confirm the diagnosis. Then we initiate the treatment, and after the patient's stabilization, we can perform the secondary or etiologic tests. We mentioned, for example, infections could be an underlying etiology, so we do not perform cultures before the patient is stabilized. Now, do you know of any medication side effects that could trigger these conditions? I need to just make it here if I missed it in the risk factors. Always remember corticosteroids as well as thiazide diuretics. And if you can commit to memory, the SGLT2 inhibitors, the new antidiabetic drugs, could also be associated with DKA with some lower values for blood glucose or even normal range blood glucose, but the symptoms and pathophysiology of DKA. Just remember this, that SGLT2 associated DKA is not necessarily associated with marked hyperglycemia. Simplify the management of DKA. The first and foremost, high flow, aggressive IV fluids. Then we continue with insulin therapy. Then we correct the electrolytes, and throughout the process, we perform the follow-up for assessment of electrolyte, glucose, and acid-base status of the patient. So I want you to understand the management of DKA as the initial management for insulin, initial management for IV fluids, initial management for correction of electrolytes, and then follow-up or monitoring-based switching in the management options. So what is the very first IV fluid recommendation for DKA? That is rapid infusion of normal saline, 0.9% NS. What are the monitoring-based shifts and switches in the IV fluid management? If in DKA patients the blood glucose levels reach less than 200, we add actually dextrose water, 5% DW. Remember, later on we mentioned in hyperglycemic, hyperosmolar state, this value for adding the dextrose water will be 250, but for DKA it's 200. Then the next question is, in what condition we switch from normal saline to half saline? That's when the sodium is normalized. Again, the corrected measures of sodium is normalized, or if the sodium values are increasing. So we calculate the sodium base of our solution based on the sodium correction, and we calculate whether or not we need to add dextrose water based on the level of blood glucose. This is the concept of monitoring based workup and assessment. Next step is insulin treatment. So what's the initial insulin recommendation? That is IV continuous regular insulin infusion. What are the secondary modifications to this? If the blood glucose drops to values less than 200 and the patient is able to eat, we switch to subcutaneous insulin. So there are some other indications for switching to subcutaneous insulin. So what are the overall indications to switching to subcutaneous insulin? One is blood glucose dropping to values less than 200. Two is patient is able to eat. Three is normalization of anion gap, and fourth is the serum bicarbonate that is at least 15 milliequivalent per liter. Put it simple, some normalization of blood glucose and some normalization of acid-base status. Is pH assessment the basis for switching from IV to subcutaneous insulin? No. Even though we say acid-base status determines switching to subcutaneous, the components of acid-base that guide our switching include anion gap and bicarbonate levels. Now, when insulin therapy should be stopped? Remember I mentioned one function of insulin is to insert potassium into the cell. If potassium reaches low levels of values less than 3.3, we stop insulin treatment. So we have initial IV, then we have switching to subcutaneous based on indications, then we have to stop insulin based on one and only one criteria, and that is potassium value. How do we switch from IV to subcutaneous? We overlap them for the first couple of hours of the switching. Okay, now moving to electrolyte management, and we of course begin with potassium. What are the criteria for adding potassium? Well, always expect to be initially faced with a patient with falsely elevated potassium levels. However, if potassium drops to values less than 5.3, even though the normal range of potassium is 3.5 to 5.3 or 4, if the potassium value drops to less than 5.3, we initiate the IV potassium. Why is it so? Again, because patients are potassium depleted. What are the indications of bicarbonate administration in patients with DKA? Severe acidosis with pH less than 7, bicarbonate that's less than 5, or severe hyperkalemia. What are the indications of phosphate in the course of management of DKA? If the value of phosphate is less than 1 milligram per deciliter, or if the patient has cardiac dysfunction or respiratory distress due to respiratory depression. What electrolytes should be monitored in the case of phosphate abnormalities in the setting of DKA? Calcium. Of course, it's logical to know that calcium and phosphate interconnected. We need to measure calcium level in the case of phosphate abnormalities. Okay, next important aspect of the management is the monitoring that we mentioned. What are the rules of monitoring in DKA? We measure blood glucose every hour, and we measure anion gap, venous pH, and electrolytes every 2 hours. How do we monitor a response to treatment? With anion gap or evaluation of the levels of beta-hydroxybutyrate. True or false? Serum osmolarity is a good measure of treatment response. That's false. True or false? Blood glucose is a good measure of treatment response in the course of treatment of DKA. That's false. True or false? Urine ketones is a good measurement of treatment response in the assessment of DKA. That is false. Best indicators of response to treatment are anion gap and one of our ketone bodies, and only one, and that is beta-hydroxybutyrate. The serum levels, not the urinary levels of ketones. Why serum osmolarity, blood glucose, or urine ketones are not good indices of treatment response in management of DKA? Simply because their correction does not reflect normalization of the total picture. For example, the serum glucose can drop to levels less than 200 while the acidemia and ketosis is still present, or serum osmolarity can normalize while anion gap and ketosis are not corrected yet. Why the measurement of urinary ketones is not valuable as compared to measurement of beta-hydroxybutyrate of the serum? Because first and foremost, beta-hydroxybutyrate is the predominant type of ketone body in the serum, and second is most of the urinary assays do not measure this, but they measure the acetoacetate, which is a ketone body that could be normally present in the body, for example in fasting status, and therefore lacks sensitivity, at least for treatment response measurement. What is the type of breathing that the patients with DKA have, and what's the mechanism? Remember, Kussmaul's respiration is rapid, deep breathing, and mechanism is a stimulation of the respiratory centers by acidosis as a means to expel as much CO2 respiratory acid as possible. However, always remember the rule of acid base, that the compensatory mechanism does not correct the initial change. Therefore, even though Kussmaul breathing in patient without acidosis could cause respiratory alkalosis, in the patient with initial acidosis, it could not overcompensate. Now, you may have a case of DKA, everything is DKA, and serum ketones are elevated, acidosis is present, but an ion gap is normalized even though patient is still acidemic after initiation of IV fluid. What could be your analysis of this scenario? Remember, the normal saline has chloride in it, right? The physiologic level of chloride. So an ion gap is sodium minus anions, that is bicarb and chloride. So if we provide chloride, we logically drop the anion gap and normalize it. And that's why after initiation of IVF, even though acidosis may still be present, an ion gap could be corrected first. Now we are moving to hyperosmolar, hyperglycemic state, and even though we have discussed most of the differences, I would like to draw your attention to the fact that, again, the cornerstone of management is this thing called aggressive IV fluid. Now, you do not need to commit to memory this number, but in practice, what is the meaning of aggressive IV fluid? That is 10 to 14 milliliter per kg per hour of normal saline. Okay, if you have a patient with some signs, symptoms that we discussed with the risk factors of any of these two short complications of diabetes, what clinical features would help you argue in favor of HHS? Remember, the symptoms in DKA usually start in a more acute or subacute manner. Also, if it is a patient with known type 1 diabetes, it cannot be HHS. In HHS, the symptoms initiate in a more gradual manner. We have more dehydration symptoms and deeper alteration of mental status, like even coma or focal neurologic signs or seizure possible. On the other side, abdominal pain and respiratory symptoms such as Kussmaul breathing is not so common. And why is it so? Because, as we mentioned, the mechanism of HHS is insulin resistance, not insulin deficiency. The patient is not deficient in insulin, therefore the patient does not have ketosis and ketoacidosis to require Kussmaul breathing, as the metabolic acidosis being compensated by respiratory alkalosis. Same way, pH assessment can be normal, anion gap can be normal, and ketones in urine and serum are not elevated. What are the blood glucose reference range and serum osmolality values that help differentiate HHS from DKA? Usually the blood glucose levels in HHS are higher than 600, and serum osmolality, as the name indicates, hyperosmolar, hyperglycemic state, is more than 320 normal reference range. Is there any major difference in the management of HHS with that of DKA? Not necessarily. We initiate with aggressive hydration and IV insulin, and we correct potassium if needed if the potassium level is less than 5.3. Thank you. This finishes our discussion of short-term complications of diabetes.